Hi, everybody. Welcome. My name is Leah Groppo. I'm one of the dietitians and diabetes educators at Stanford Healthcare. Today, I have the really great pleasure of introducing Dr. Marina Basina. She is one of our clinical endocrinologists and clinical researchers, and her focus really lies in the diabetes management and diabetes technology. Her primary interests are in type 1 diabetes, diabetes technologies, and diabetes in pregnancy. She has a very busy clinical practice at Stanford Healthcare Hospital and Clinic, seeing patients in both inpatient and outpatient settings. She serves as a medical director in inpatient diabetes services at Stanford. Dr. Basina has received numerous teaching awards and a Stanford Hospital Award for Excellence in Patient Care. I was actually there to help cheer her on when she received that very prestigious award. Such a great honor. She leads support groups for individuals with type 1 diabetes. She is an active member of medical advisory boards for several community diabetes organizations. She co-chairs of Data Science Committee and Type 1 Diabetes Exchange, Cardiac Therapy Foundation, Sugar Mamas, Beyond Type 1, and gives educational talks for patients on a regular basis. So without further ado, Dr. Basina, take it over.
Okay, thank you very much, Leah, for the introduction, and thanks everyone for joining us today. So I will be presenting you a topic on diabetes, pregnancy, and importance of preconception. That is very important topic, and it's dear to my heart because I think it's extremely important, and I hope to convince you in the same by the end of my talk. So we will start with some of the statistics that it seems to be that pregestational diabetes happens in only 1 to 2% of pregnancies. But because overall incidence and prevalence of diabetes is going up, more and more women of course, diabetes care is improving, and the fertility treatment is advancing. There are more and more women are getting pregnant with diabetes. Most of the women are women with type 2 diabetes, so pre-existing type 2 diabetes before pregnancies. So those women are at a high risk for mothers for miscarriage, early miscarriage, developing preeclampsia, which is high blood pressure associated with pregnancy, hypertension during pregnancy, maternal birth trauma, the need for C-section, delivery before the 37 weeks of gestation, and all those complications and risks are about 4 times or more higher than in women who are pregnant without diabetes. The fetuses, the babies, are at risk for for the gestational age. And we'll talk about that more, delivering larger babies, having trauma at birth because of the large weight, heart problems, respiratory problems or breathing problems, and different metabolic complications such as low blood sugars, high liver tests with a high bilirubin, low calcium level, and high hemoglobin hematocrit, which causes the blood to be more sort of viscous or thick. Lower diabetes duration and lower hemoglobin A1C, which is a measure of 3 months glycemic control, comparing to type 1 diabetes individuals. The risk of complication is actually if you have good controlled A1C and controlled blood sugar, so the risk of complications is significantly lower. What are the possible explanations for all of the above that we just talked about? So we do have increased prevalence of obesity, blood pressure, even without hypertension, so preceding the conception, and features of metabolic syndrome. All of those will determine or lead to higher rate of perinatal mortality, meaning the the fetal and maternal complications, including up to death around the delivery time. The babies of mothers with type 2 diabetes also are under significant increased risk of metabolic complications, such as diabetes and obesity later in life. So if you think about pregnancy planning, think about your future children and how important it is for them to be able to get and to grow healthy kids and into healthy adults. So what are the statistics? Despite all the benefits of the preconception care and all the literature and sort of explanation how important that is, women with type 2 diabetes are still less likely to follow the preconception programs comparing to women with type 1 diabetes. So it's only a third of the women with type 2 diabetes attend those programs, comparing to over 50% of women with type 1 diabetes who attend those programs. So this is a missed opportunity to improve the outcomes for both moms and babies, which is, again, extremely, extremely important. What I usually tell my patients, and what the worst thing for me to hear is after something happens during pregnancy or delivery, to hear from women, only if I would have known this before, I would not have done this. So this is what my main goal for the talk is, to increase the awareness and to let you all know how important this topic is. So we do know that incidence of congenital malformations related to the increase in hemoglobin A1C, which is reflecting worsening of glycemic control. And this is in very early pregnancy and pre-pregnancy when most of the organ formation happens. Glycemic control should be optimized before the conception. Again, I'll show you the data why. Studies showed that the risk reduction of congenital malformations by 71% and reduction of perinatal complications by 54% if glycemic control is improved prior to conception. Pre-pregnancy care is associated with reduction of preterm delivery by 15%, risk reduction of the small for gestational age babies by almost half, and the risk reduction for need for the babies to be admitted to intensive care unit by quarter by 25%. So it is a huge impact on the health of mother and the baby. So what are the targets? National Institute of Health and Care of Excellence, which is the abbreviation is NICE, and American Diabetes Association ADA guidelines advises that before the conception, the goal for A1C should be less than 6.5%. For women with type 2 diabetes are generally advised not to get pregnant until A1C at least less than 7%. Or again, if can be safely achieved 6.5% because of all the risks that are associated with it that we just discussed. Now, what are the psychological or physiologic and psychological issues with transition to motherhood? It's a huge kind of stress, right? It's a stressful time. There are specific stressors. So before planning the conception, you're only worried about yourself. But when you're planning for the health of your future child, you are thinking about how you would be intensively manage your glucose during pregnancy. That with the intensification of glucose control, the more frequent hypoglycemia can happen. Women may have fear of losing control of their body and losing control of their own diabetes care. Anxiety about adverse pregnancy outcomes, again, because you're worried not just about yourself, but about your future child. Meticulous planning of all the daily activities, including meals, frequent contacts with us as healthcare providers. So all of that adds to stress of the early pregnancy and preconception. So patients worries about feeling judged, looking at their blood sugars, that their diabetes knowledge that they had over the years are now being questioned. That somebody is taking away of joy of their overall pregnancy experience because you are under such a stress to keep your blood sugars under very tight control. So many women actually report negative interactions with contact to their medical team. So it's important to establish your good medical team when you're thinking about getting pregnant. So it is important to find your team, your multidisciplinary team, and also connect to the community. So there are many online support groups like Sugar Mamas of type 1 diabetes, and this group is expanding to type 2 diabetes. In American Diabetes Association website, there are recommendations beyond type 1. So all of those online organization providing support and providing a lot of handouts and information. And knowing that pregnancy can be successful and rewarding, and it's definitely worth it as long as you get enough time and good planning for it. So what are the main goals for preconception care? So the main one is to reduce the risk of adverse health effect for women, fetus, and neonate and newborn, and future health of your future child. Optimizing health, addressing factors that can be modified, educating yourself about healthy pregnancy. And for all women and men of reproductive age, preconception counsel should be offered. And women should be counseled on seeking medical care before attempting to become pregnant. So as we already mentioned, that pregestational diabetes associated significantly with increased risk of congenital anomalies and also pregnancy-related complications. It's important to have at best glycemic control as possible before pregnancy and during pregnancy. It is extremely important to optimize the weight management in the context of the improved blood sugar control, because the insulin requirements or the medication requirements can change with the weight loss. Consideration should be given for testing of different complications of diabetes, such as microvascular complications with eyes and kidneys, having seen your eye doctor for the examination, seeing your primary care doctor or kidney doctor, and sometimes getting a 24-hour urine collection if needed for protein testing, getting electrocardiogram or other tests to make sure that your cardiovascular, your heart disease, your heart health is good. Thyroid function tests is important to check in women who have diabetes before pregnancy. So the screening test for thyroid function test is recommended. And again, as we mentioned, less than 6.5% for hemoglobin A1C is a target that had been shown to significantly reduce the complications. So what are the key components for preconception? Education, that's number one. It should be patient-centered. It should be supportive, and the goal for it is to minimize treatment-related distress. So the actual regimen that will feed your lifestyle, that will feed your needs, but on the other hand, to be safe and effective. And also to plan what kind of care would be done during pregnancy. So management of high blood sugars before the conception. So again, to achieve the target before pregnancy. What is diabetes self-care? How do you manage your low and high blood sugars? And also, if some of the complication already had developed, how do you optimize these complications associated with diabetes? What kind of medications can still be used for preconception, or can medications be adjusted to be safe for pregnancy? So what is the preconception period? What's the length of this period? And when do we start to kind of think about, is there time for me now to decide, or do I have another few years, or maybe I'm too late in the game? So the definition had been kind of variable. Some studies report that the most important would be 3 months prior to conception. A lot of data showing that it should be a minimum of 1 year prior to initiation of any unprotected sexual intercourse that possibly can result in pregnancy. And in terms of the different definition of preconception period, there are sort of different perspective of it. So one perspective is the biological. So what is the actual effect of all the tissues preparing themselves for conception? So this kind of critical period, which is 2 to 3 months before conception, for this reproductive cells formation and for early placental development. Again, mostly women don't know when you get pregnant within the first 2 to 3 weeks, right? So, but that's when most of the organs start developing, and including the neural tube, the whole central nervous system of the baby will develop within the first 3 to 4 weeks of conception. So of the getting pregnant. So it's extremely important to have planned pregnancy, so to avoid any of the complications. So we do recommend starting folic acid at the minimum before 4 to 6 weeks before conception, and that have been shown to reduce the complications or the neural tube defect by 70%, which is a huge reduction. So also there's a sort of individual preconception period is whenever a couple decides to have a baby, which could be 6 to more months to achieve healthy BMI, healthy diabetes control. So whenever you discuss that the family is ready now to start the preconception or to start talking about the pregnancy. So again, it's extremely important to think about what kind of measures should I take to achieve my healthy pregnancy? What kind of dietary or exercise modification? How can I achieve my healthy body mass index to optimize and to have my perfect pregnancy outcome? So when you see your doctor to discuss the visit and discuss your desire to start the family, it's important to discuss what contraception do I use until I achieve my glycemic control, until my body mass index and my nutrition is on exercise is all optimized. So coming up with a goal of what contraception to use that would be safe and effective before getting pregnant. Now, the important to decide if you're on insulin or if you're on oral medication prior to conception, knowing that during pregnancy, it's mostly insulin that used. We usually, and the gold standard recommendation to go on insulin during pregnancy. So discussing with your healthcare provider what kind of insulin therapy I will be using during pregnancy. If I'm on multiple daily injections already, would it make sense for me to think about insulin pump therapy? Would it make sense to continue my MDI stands for multiple daily injections? What type of insulin will I be on during the pregnancy, and how would it change as the pregnancy progresses per trimester? How do I safely intensify treatment to achieve glucose target of less than 6.5%? If I'm already on antihypertensive medication or cholesterol medication, revising that therapy and to decide what are the safe medications for me to use, or if not, what kind of medication can be used instead. Re-education about diabetes, as we mentioned, assessment for thyroid function test, and supplementation of folic acid for at least 4 to 6 weeks before conception. Again, this is a kind of a difficult, so you can start a few months before conception, and it would be at least 400 micrograms per day. And education is important. Again, evaluation on and treatment of any possible complications that already happen, and seeing specialists for eyes, for kidneys before the conception. So those are really, really important. So what are the differences between type 1 and type 2 diabetes? Women with type 1 diabetes are more likely to have pre-existing complications such as eyes and kidneys. Knowing that these complications actually can worsen during the pregnancy is very important. And again, it's extremely important to see a specialist to be evaluated at what level those complications are, what is the baseline, and how can we work together to prevent those getting worse during pregnancy. What is the risk of low blood sugar? So for severe hypoglycemia, because at different stages of pregnancy, there is an increased risk for low blood sugar. For type 1 diabetes, also, there is an increased risk of diabetes ketoacidosis during pregnancy. There is in type 1 diabetes a higher rate of fetal growth restriction or small for gestational age. We're mostly talking about large babies and large for gestational age, but we should not discount small for gestational age, which is very important as well. And risk of congenital anomalies are really quite high, about 7.5%. For type 2 diabetes, pre-pregnancy, preconception A1C usually lower. The duration of diabetes overall is shorter, but women may have higher body mass index. They would be at older age. And look at the rate of the congenital anomalies. So actually even higher than in women with type 1 diabetes, probably because of all other metabolic factors that are involved. So what are the congenital anomalies that we're worried about? There is a 2 to 4-fold increase risk of overall congenital anomalies in pregnancies with diabetes comparing to non-diabetes pregnancies. The incidence is related to degree of high blood sugars, of hyperglycemia, and again, in this periconceptional period is extremely important. It has been shown that risk increases proportional to hemoglobin A1C level. With A1C of 5.5, the risk is 2 to 3%, which is similar to general population. But as the A1C goes up, 7.6%, the risk doubles. And if A1C is over 14%, the risk is really high, 20%, which is 1 in every 5 kids born with congenital anomalies. Now, what's important to know is that for 1% decrease in A1C, there is a 30% reduction of major congenital anomalies in both type 1 and type 2 diabetes. Again, that emphasizes how important it is to achieve good glycemic control, not during the pregnancy, just during the pregnancy, but actually for planning and for preconception. So what are the most common congenital anomalies? The heart complications are the most common ones. So congenital heart disease. And those are pretty severe conditions that require multiple step surgeries. So babies will start having surgeries sometimes before the age of 1 year old, and then continues having those stepwise surgeries until they're sometimes 7 to 9 years old to 10 years old. So those are not easy ways to go through as a family, to have your child going through those surgeries and recovery after those. Neural tube defect, as we discussed, would be absence of brain, which is anencephaly, spina bifida, so the effect of the spine, hydrocephaly, which is the fluid in the brain, anomalies in the urogenital tract, sacral agenesis. So here you can see the twin babies that were born with diabetes mother who is not controlled, and you can see the sacrum, how it's underdeveloped, and for those babies are going to be having very long recovery, and we don't know what the outcome is going to be. So pre-existing diabetes and obesity together will cause even higher risk of anomalies. So what are the possible explanations for that? Would be this oxidative stress. It could be different gene effect, gene expression, excess apoptosis, which is cell death in those developing organs of those little ones. So preterm birth, much more common. Preterm birth could be either just spontaneous, just delivering early, or medically indicated because of the different medical conditions that necessitate early induction or early C-section. Or it would be from maternal side, from mom's side, or it could be obstetrically indicated. So if the baby is too large, or if the baby is developing some kind of conditions intrauterus that require early pregnancy delivery or early delivery initiation. So 22% women with diabetes will have need for either spontaneous medically or obstetric indicated preterm birth, comparing to 4 to 5% of women without diabetes. So it's 4 or 5% fold increase. So it's quite significant increase. With the higher level at A1C, the risk is increased markedly. So even you can see, even if A1C is at perfect target, less than 6.5%, there is still increased risk higher than in general population. It's 13%. But you can see how dramatically risk goes up if A1C is at conception is over 9%. So again, it shows the importance of planning. So large for gestational age babies. The definition is to have to be over 90 percentile for gestational age measured by ultrasound, or the babies, the large babies that are born 4 to 4.5 kilos or over 10 pounds. So this is kind of the classic appearance of the babies born from mother with diabetes. So you can see those fat pads that are so prominent in the kind of the chest and upper back and lower jaw, right? And disproportional macrosomia, meaning that increased weight to length ratio. In study with type 1 diabetes, it shows that large for gestational age was 41% incidence and macrosomia was almost 20%. So really, really high. So periconceptional and early trimester hyperglycemia, again, when women are not even aware about their pregnancy, plus later gain weight in pregnancy are the triggers for those complications. Other contributing factors being obese pre-pregnancy, gestational weight gain, and variability of the blood sugar during pregnancy. So why are we worried about those large babies? So it can actually lead to shoulder dystocia. So babies are not able to get through the birth canal and kind of get stuck at the birth canal. And it happens 5 to 9% among infants over 9 pounds or close to 10 pounds or more. So other risks, again, as much as we worry about large for gestational age, we also worry about babies not getting enough nutrition or being small for gestational age or restricting growth in the uterine. So this is double the risk in type 1 diabetes, women who already have eye disease and kidney disease prior to pregnancy. So all of that increases fetal or babies born, newborn mortality. Other complications, the babies get very low blood sugars, and you can see that thin, underdeveloped baby. They go to respiratory distress requiring NICU or neonatal ICU admission, low calcium level, high bilirubin level, and mortality is 5-fold higher if preconception A1C was over 7.8%, which we think is not that high, but it's actually significantly affecting the pregnancy, as you can see. So what are the long-term consequences? Again, we said it's important to think about not just women just by ourselves, but think about the babies that we bring to world. And those babies are at a high risk for obesity, diabetes in their life, cardiometabolic risks. And this is due to defect or effects of their uterine environment where they grew up for the first 9 or 8 months. And this programming neonatal in addition to other different factors. So for mom, what are the complications for mom, obstetrics, and other maternal complications? So again, would be early pregnancy loss, preeclampsia or high blood pressure during pregnancy, polyhydramnios, which is a high amount of amniotic fluid. The pathogenesis is being debated, but it's likely that the insulin does not cross the placenta. It's the sugar crosses the placenta. So imagine if you blood sugar is high, you go to the bathroom more. So do the kids or the fetuses inside the uterus. So if they're exposed to that high mom's blood sugar, they pee more. And that's where do they collect their urine? It's in the amniotic fluid, right? So there would be polyhydramnios, or a large amount of amniotic fluid that is significantly associated with different congenital anomalies and the need for C-section. So for moms would be low blood sugar, progression of their microvascular complications such as eye disease, kidney disease. So per statistics, 50% of women who have kidney function at about 50% of normal develop worsening of their kidney function during the pregnancy, including getting to the end-stage renal disease. It's cardiovascular disease. It's peripheral autonomic neuropathy, which is different organs, including stomach and nerves, and diabetes ketoacidosis. So pregnancy is a very interesting state in terms of the glucose metabolism. So we call this metabolism accelerated starvation and facilitated metabolism. So if you look at this graph, it sort of shows what's happening. So if you look at the non-pregnant women, this is a woman without diabetes. So in normal pregnancy, what happened? So if we're not pregnant, this is the shaded line is what happens with the blood sugar. So blood sugar spike a little bit after meal, then return to baseline, then spike a little after meal, then return back to baseline. So what happens during the pregnancy? It's accelerated starvation. So the body is just grabbing that glucose as much as possible. So it spikes. But at the same time, metabolism is super fast because you're feeding not just yourself, but the baby. So some of that sugar that you're eating floating through the placenta to the baby. So blood sugars actually drop low in between the meals. So this is, again, normal pregnancies. And then again, spiking after the meal, you can see even higher than before pregnancy, and then dropping and spiking and dropping. So this is, again, normal glucose metabolism during pregnancy without diabetes. Now, what are the glucose target during pregnancy? So those targets are really tight, and that's why it's important to plan what kind of method of treatment will be used during pregnancy. So fasting glucose is important to keep under 95. So one of the most important targets for the glucose during the pregnancy, it's a 1 hour post meal that should be less than 140, and 2 hours, and this is starting from the first bite of the meal, and 2 hours to be less than 120. So how do we evaluate and manage? So again, as we discussed, we're coming back to the same thing. Preconception planning is the key for successful pregnancy outcome. It showed significant reduction of congenital malformation, preterm birth, perinatal mortality. Counseling on how to achieve glycemic control, how to reduce and improve those fetal and maternal outcomes, how to achieve this glycemic control with some burden, but that minimum as possible, and avoiding significantly low blood sugars. How do we go into adjust the medications, and how we are doing with the diet? What kind of diet will be during the pregnancy, and how do we maintain this diet? And speaking of the diet, I actually usually advise my women who were talking about patients who were discussing the pregnancy planning to try this diet prior to pregnancy to see how do you feel about this and how do you distribute those meals throughout the day. So it's 20 to 30 grams of carbohydrates for breakfast, or about 10 to 15% of the total daily carb intake, about 40 grams for lunch, or 30% of the total daily dose of carbohydrates, 2 to 4 snacks, and snacks would be between each meal. So between breakfast and lunch, between lunch and dinner, and before bedtime. And it would be about 10 to 20 grams for each snack. Timing of meals and snacks would be important to prevent those hypoglycemia, and the reason that I showed you on the previous slides about this metabolism specific for the pregnancy. So a lot of women now, and I included this information just for you to FYI, because a lot of women for diabetes would treat it with those agents, the GLP-1 or glucagon-like peptide agonists, those such as Ozempic, Mounjaro, Trulicity, and others. And it is important to be on these medications because 34% of women of reproductive age qualify for obesity diagnosis. So when to stop those medications? So that's a big question, and it's being discussed in medical community and addressed in research. So I thought it would be an important topic to talk about. Women with polycystic ovarian syndrome or with diabetes and obesity or diabetes is overweight, frequently treated with either those medications or metformin or both. And it had been shown that actually those glucagon-like peptide medications could be more effective than metformin in PCOS. They showed that they can improve menstrual regularity. Now, those receptors are actually very highly kind of distributed, widely distributed throughout the body, and they are present in reproductive system. So because we know that obesity by itself decreases fertility, and it's independently associated with increased risk for anovulation, it also leads to poor oocyte and embryo quality, even for IVF pregnancies, for in vitro fertilization pregnancy. It reduces endometrium receptibility, so meaning that implantation of that sort of fertilized egg into the endometrium, into the uterus. And weight loss agents are effective in reducing all of that and improving, but they should be stopped before conception. So there is a lot of discussion, what are the risks and benefit? Because what if I stop my medication and regain my weight? Is it more beneficial to continue medication till the conception? Or is it okay for me to stop the pregnancy and to stop the medication and wait for pregnancy to happen with the risk of gaining weight during that period of time? And that's sort of topic open to discussion. Because GLP-1 agents are considered class C, so not approved for pregnancy. In the animal studies, they do cross the placenta, and they can cause growth restriction in some congenital anomalies. This has been done in animal studies, the studies have not been done in humans, but there were several trials that are listed here with relatively small number of patients, 176, 160, 28 patients who were treated with different GLP-1 agents. Didn't show significant anomalies in children, and actually natural conception rate was higher in this woman. So again, the jury is still out there, so we don't have great guidelines to what needs to be done, but to sort of minimize that time period between conception and the stopping those medication. As of now, it is accepted that the washout period of 1 to 3 months should be sufficient, but again, data is limited. And I listed quite a few papers or studies that had been done, but again, relatively small number of patients studied. So to summarize, for pregnancy planning, family planning with the use of effective contraception is critically important. It's critically important to build your multidisciplinary team who you will be trusting and go into for preconception and throughout your pregnancy, and develop good relationship with your team. So this is very important. So healthy pregnancies with women in women with diabetes starts before conception. So this is the most important message that I wanted to provide you today. So diabetes can be a challenge in pregnancy, but education, close monitoring, latest therapeutic modalities, women can have healthy newborns. Close attention should be paid to diet, glycemic control, metabolic stressors, early diagnosis and monitoring of all the complications, and the pregnancy will be successful and not a stressful experience. Diabetes should not stop women from experiencing the possibility of having children. And advice is to educate yourself as much as possible. Make commitment to yourself. This is commitment not just to yourself, but for your future child and for your whole life of your future child. So always try to put your baby first as much as you can while you're pregnant. And not only while you're pregnant, but while you're thinking about pregnancy and getting and conception. So thank you for your attention, and I'm happy to take questions if there are any.
I don't see any questions right now, Dr. Basina. So yeah, everybody please feel free to ask your questions. What a really insightful talk. I learned so much. And I really liked how you highlighted the nutrition component and even trying the diet out beforehand and even seeing like where the barriers or how the tricky parts of the diet and problem solving with your team. I think it's great. Yeah, I don't see any questions. Is there, yeah, anything else you kind of wanted to share? I feel like your passion for this topic comes forward so much because I know you do really see a lot of patients and want to help. Oh, you do have. So this person put a question in the chat. I'm actually not sure how to pronounce that.
Yeah, will the oocyte, I can read it. Will the oocyte quality improve with weight loss? Yes, it had been shown that the oocyte quality improves with weight loss and improves with glycemic control. And ovulation rate, even natural ovulation and natural conception improves with the weight loss and glycemic control. So even the prior studies with metformin alone showed that metformin alone can restore ovulation and cyclic sort of menstrual cycle regularity in up to 30-40% of women just by using just metformin and with some weight loss. Yes, so absolutely.
Yeah, great question. Any other questions? Oh, is intermittent fasting harmful for pre-planning when you're living with prediabetes?
Sorry, can you repeat the question?
Oh yeah, I think this is around preconception, but is intermittent fasting harmful in prediabetes with preconception?
So great question. I don't think there were any specific studies on that, but I don't see from medical standpoint for preconception that it would be any harm. We do not recommend it for during pregnancy because of the reasons that I reviewed for sort of metabolism, glucose metabolism during pregnancy, and the need for the babies to have the glucose continuous kind of flow of the glucose, but for preconception, I don't see any reasons for it being harmful. So yeah, I think it's totally fine.
Yeah, thank you. I think one more question. Oh, Maura, thank you. Thank you for all the wonderful and useful information. And then what are the risks to women who get preeclampsia in the 36th week, meaning at the end of their pregnancy?
Yeah, so it's a great question. So it's kind of can be a whole hour of discussion. But it is very important for women with history of preeclampsia or eclampsia during the pregnancy to have continuous monitoring after delivery. So continuously monitoring the blood pressure. Usually women still require, even the women who did not have hypertension before conception or before getting pregnant, may require a treatment with medications for blood pressure for at least 6 to 12 months after delivery. Those women considered being under high risk for heart disease and hypertension and cardiovascular disease after pregnancy. So very careful monitoring and thinking about those women as high risk for heart disease, basically using all the measures that we use for patients with high risk for heart disease, going earlier, maybe on cholesterol lowering medication, checking the urine test at least annually for microalbumin, getting blood pressure control really tight or really well controlled during like after pregnancy. So again, this is very important to have a very close follow-up. It's a great question, and it's very, very important to keep that in mind, that that needs to be very closely followed. Yeah, so great question.
Yeah, this is another really great question. What strategies would you use to counsel a pregnant patient with diabetes who is emotionally overwhelmed and adheres to cultural dietary practices that conflict with medical nutrition therapy recommendations?
Yeah, so that's an excellent question, and Leah can feel free to chime in and talk about this. But
Oh,
I think it's very important. It is overwhelming. So you are it's kind of how do you combine the cultural practices with the medical nutritional therapy? I think working with your nutritionist, and again, pregnancy planning comes to the very, very important point of that. So discussing, seeing your or creating your multidisciplinary team, finding the nutrition who can work with you on creating your meal plan with specifically culturally plausible or good that would work for your specific diet and for your specific way that you eat. So that's what I think is important. And again, it's important to plan because all the tasting buds can totally change during pregnancy. So having different variations of the diet is important, because something that you think might be good and that you like now, it could be totally different during pregnancy, right? So for women who have been pregnant, know that can totally change. So that continuous follow-up and continuous discussion, starting with pre-pregnancy and thinking about what kind of portion size, what foods, how I would distribute that in between my meals and snacks. And that can be all adjusted to your cultural preferences. It's not the type of food necessarily. It's more the amount of carbohydrates and the portion size and those composition of those meals with combination of those proteins, fat, and healthy fats and the carbohydrates. That's what's important. Yeah, excellent question.
yeah, definitely. I definitely echo that. And as a dietitian, I think for medical nutrition therapy, your registered dietitian can partner with you in creating kind of meal ideas and suggestions that fit into your current cravings. Because as we know in pregnancy, the body and cravings sometimes change, like Dr. Basina mentioned. And sometimes I find it really helpful if someone, if you're working with someone and they just come to you and they say, I'm feeling overwhelmed about everything right now, because then you're both able to have a very open conversation about it. And some people come to visit and want lots of information, and some people want to really have that relationship. So hopefully you can find someone that can help, because it can be very overwhelming.
Yeah, for sure.
So your next question, in your review of glucose targets during diabetes pregnancy slide, you shared what blood sugar should be while fasting and 1 hour post and 2 hour post a meal. What was for women who are pregnant for preconception?
So those targets are established and recommended during pregnancy, not for preconception. But I think it's important to know about those targets, what they will be during pregnancy, and try to see how can you achieve it. And that's why I usually encourage women to try that pregnancy diet and see with this pregnancy diet, how do I achieve those targets? Is it because those are very tight target and not possible to achieve, not always possible to achieve. So that's why it's important to try and to see how can you do it in the real life? Yes, so, but those targets had been established for pregnancy, not for preconception. But if you can achieve those targets for preconception, your A1C would be ideal and perfect for conception. So I would say you can extrapolate it.
Yeah, thank you. And then can the women who have preeclampsia at the end of their pregnancy still be able to reduce the risk for heart disease, even if they didn't catch their evolving hypertension for many years, say 10 years?
Um, Yeah, so if you have all your risk factors controlled, so that's if you can definitely reduce the risk of cardiovascular disease. But it's was just what I was trying to emphasize, that it's important to get good follow-up. So don't get because after babies are born, obviously everyone gets super busy and babies become priority and not our own health is on the first plane, right? So don't forget about yourselves. And that is important because you want to be a healthy mom and you want to be keeping up with your child, the kids when they grow up. So that's important to pay attention and to be followed for those complications. But yes, you can avoid those risks by, again, post-pregnancy, avoiding the weight gain, avoiding the unhealthy nutrition, maintaining regular exercise activity. So all those lifestyles and taking the medications are really important. And yes, you can significantly reduce the risks. Absolutely.
Okay, here's another question. Somebody is saying that they have an adopted child. And is there any kind of way to know or test to know if the biological mom was living with diabetes and if kind of those things that you had mentioned might be affecting that adopted child?
So like not the biological mother, right? That's what the question is.
Yeah, not the biological mother.
I think it's more of the child, like seeing what environment they grow into, right? So again, healthy nutrition, because I think it's important for our children to see when they grow, they see what their families are doing. They eat with the family and having family meals and showing that healthy nutrition is important and healthy lifestyle is important. That so that would be important because it's not like it's in the genes, right? Because it's not a biological child, but the home environment would be extremely important as well.
Yeah, thank you. And then this is another question. If the father has diabetes, does that affect the baby if the mother does not live with diabetes or is not pre-diabetic?
Yeah, that's a
Sorry, or is pre-diabetic?
yeah, that's a wonderful question. So it depends on what type of diabetes, if it's type 1 or type 2 diabetes. And I actually was giving the talk, similar talk to the fellows this morning, and we had discussed that exactly question that we have a lot of studies done on preconception for mom, maternal outcomes, for maternal fetal outcomes. There are barely any, if any, data on the dads. How dad's diabetes control, how the sperm quality control with the diabetes control, how does that affect the healthy babies? So I wish I would have a good answer for you. I don't think there's a lot of data. So if we do know for type 1 diabetes that if father has type 1 diabetes, the risk for child having type 1 diabetes is actually higher than if the mom has type 1 diabetes. So that part we do know. In terms of the type 2 diabetes, unfortunately, I don't think there is data on this. But theoretically, you would think that yes, the healthier the father, the healthier so because the half of the genes come from dad, right? So it's important to have from both sides to be determined to have a healthy child. But do we have the good data to support it? Unfortunately not. So this, I think, should be done in future studies. But yes, excellent question.
Yeah, that is an excellent question, and hopefully the research will happen. This is another question. Any collaborative work with a dental team? In what ways can the healthcare team collaborate with a dental team to ensure comprehensive care for a pregnant patient with living with diabetes?
Yeah, also great question. So periodontal disease, as we know, is much more common in women, or in individuals, and in individuals with uncontrolled diabetes. So it is important to have a good dental exam because with the um, healthy teeth and gums, it's important to because that can develop into different infections, and those infections can cause other complications. Is there kind of collaborative studies or work done? I'm not aware of this. I think, again, it's a wonderful point, and I think it should be done, but not that I know of. So we do encourage women to have dental exam, definitely, and to do all their, the root canals or anything or infections that need to be taken care of. But is it a part of sort of a comprehensive care? It's mentioned, but I think it's underemphasized. I totally agree with you on that.
Excellent. Once we all got started, such amazing discussion.
Yeah,
Thank you all so
wonderful.
much.
The questions are so great.
Yeah, really excellent questions. Thank you all so much for coming. And we hope to see you next month on Thursday from 5 to 6. And yeah, people are saying thank you, Dr. Basina. Great session. Yeah, we feel so fortunate to have your expertise and your knowledge and such a great presentation with so much data. Thank you.
Thank
Bye,
you. Thank you
everybody.
for all the wonderful questions.
Bye.
Bye. Thank you.